Alrighty, hello everybody. So this is my second time recording this because I'm a dumb butt and I recorded without any audio. So this is going to be our pharmacology review part 1, and this is going to be basically our respiratory and GI drugs. So without further ado, we're going to get right to it. So some general tips for studying. Firstly, it's very important that you know the medication name and the drug class name because you may, on the test, get the medication and not the class. So you need to know what medication belongs to what class. Remember your key drugs. Remember you gotta know that specific drug generic names. Generic names are gonna be what's on the NCLEX and not the brand name. For example, some people know ondansetron as Zofran. Well, they're gonna see ondansetron on the test rather than Zofran. And you need to know what that medication does. Maybe they'll see lisinopril. Well, you need to know that that's an ACE inhibitor. I mean, it might be a different generic name from the drug that you take, but on that test, it's going to be that generic name. Remember, you want to know study by classes, and you want to make sure that you read the questions carefully. Remember the negative questions. Remember those incorrect answers. Remember the further teaching. Remember the lack of. My personal recommendation is if you think that you know what the question's asking, you probably don't and you need to reread it again. Always reread it twice. It'll help you comprehend better. Remember, if your select all, that applies. Remember, you want to treat them as true, false, or yes, no. Remember, if this is true, it's true. If it's not, it's false. Don't ever think about it as a choice. Always true, false. So now, we're going to go ahead and start doing our respiratory drugs. So the first thing we have here is we need to educate our patients on how to use a meter dose inhaler. For any patient prescribed an inhaler, the nurse should ensure the client can self-administer the medication. So we're going to need to do that teach back. Why? Well, if we have a patient that has an inhaler and they get in a crisis situation, for example, they have an asthma attack, they're going to need to know how to administer that inhaler. If they don't know how to administer that inhaler correctly, then their asthma attack's not going to be able to be cured. And so we need to make sure before that patient leaves the hospital or the unit or the clinic office that they know how to administer their inhaler correctly in case of an emergency. Remember, the patient should always wait 1 to 2 minutes between puffs. They need to wait 5 minutes between two different inhalers. They should always take a bronchodilator before corticosteroid. Remember, B before C, because bronchodilators are going to dilate your muscles in the lungs, while the corticosteroids can help with that inflammatory reaction. Remember, they always need to keep track of doses on their inhaler because the patient may have an asthma attack and they go to get their inhaler and maybe the inhaler's out. They need to make sure that they refill their inhaler or open up a new inhaler when the old inhaler is done. So every time they use a medication that's an inhaler, they need to keep track of that dose because we don't want them in an emergency situation to not have their inhaler with them and not have enough medication in it. Remember, process of opening that new inhaler. They always need to shake it and test it before use. They can use a spacer if needed to get more medication to the airway. If the patient uses a steroid, this is key information. If they use a steroid, they have to wash their mouth out after use because we don't want a fungal infection to occur from that steroid medication. That's why we also need to wait 5 minutes between those inhalers because we don't want any infections to occur. The patient should hold their breath for 10 seconds after receiving a puff because that's going to allow enough time for that medication to reach the lungs and to start to work. Alrighty, difference between short and long-term treatments for asthma and COPD. So, a lot of our short-term asthma treatments is going to be for those acute asthma attacks. So they're going to have that asthma attack whenever they're walking, maybe they're exercising. Our medication, the key medication we need to use here is the albuterol. So albuterol is a short-term bronchodilator, and it acts as a rescue inhaler during those asthma attacks because it's going to work quickly and it's going to last longer. And with our patients with acute asthma, they need something that's going to open their lungs quickly. We don't want to wait on a medication to work. We want to make sure that patient can breathe quickly, and albuterol is going to help do that. We can also use antiderivatives, can also help dilate the airways in short-term asthma, but we tend to not use this because it has high drug interactions in the body, and we don't want that to happen. We can use IV or inhaled glucosteroids. Remember, we have to use that combined treatment. Remember, a bronchodilator should never be used alone for asthma treatment. They can use a steroid to help with that. For our long-term asthma treatment, these are going to be for our chronic asthma patients, and these are going to help with our control. We can use salmeterol, which is a bronchodilator. It's used to control symptoms of asthma. Remember, we never use it alone. We have anticholinergics. We can use ipratropium bromide, and it's going to be for that long-term asthma prevention. A lot of these medications are going to work very slowly, and that's why they're not preferred over our short-term treatments for when that patient's actively in a asthma attack, because they're not going to work fast enough. They're not going to be able to dilate those lungs quickly. We want to make sure during that short-term asthma attack that that patient can breathe. These are going to help open the lungs, but it's not going to do so for that patient in an asthma attack. COPD treatment. So a lot of our COPD patients, they have a problem with their lung compliance. Their lungs are not able to open up as much as a normal lung can, and that's why they have trouble breathing. And a lot of their lung compliance is low. And with a lot of our treatments, we have to be very careful to not give them too much, to not give them too little, because we want to make sure that they can maintain a stable breathing pattern. We can use, for COPD patients, we can use albuterol if needed. We can use steroids. However, we need to make sure that their O2 saturation is between 88 and 92%. Because why is it 88 to 92%? Well, it's because their lungs aren't able to work as well as a normal lung can. Their lungs can't expand well. They can't get enough O2 in there. Lungs can't handle it. So that's why we have to target it here. We can use oxygen to help get O2 in the lungs, but we can't hyperoxygenate these patients. Their lungs can't handle it. Alrighty. Rescue inhalers versus long-term management inhalers. So rescue inhalers are going to be like albuterol, epinephrine. Epinephrine works for that sympathetic response. Sympathetic responses are going to help dilate those vessels. It's going to help get more blood to those areas during times of stress. And during an asthma attack, we need to make sure that those airways get open. We can use metoprolol, and we can use that steroid, of course. Steroid, inhaled, IV. Long-term use, we can use that salmeterol, ipratropium, theophylline, montelukast, or fluticasone, which is our steroid. A lot of these long-term medications are going to be that prevention of asthma. So they're not going to use to be treating that asthma attack. It's going to be more about that prevention. Treatment of acute asthma, again. Yes, we can use oxygen because during an asthma attack, that patient's lungs are constricted. They can't get enough oxygen in to get to the rest of the body. That means during an asthma attack, that patient can't breathe. Because they can't breathe, they can't get oxygen into the bloodstream to the other organs. So by placing a little bit of oxygen on them, it's going to help get that oxygen to parts of the body that need it. We can use, of course, albuterol is going to be that key medication. We can use corticosteroids. We can use ipratropium bromide. Our goal is to relieve hypoxemia, reduce airway inflammation, especially with that corticosteroid medications, and relieve that obstruction if there is one. Now, since we've kind of dipped into bronchodilators as well as our glucocorticosteroids, we're going to go into a little bit more detail about them. So bronchodilators. Our mechanism of action is that they mimic the sympathetic nervous system and open up the lungs and stimulates beta receptors. They're used for fast-acting acute asthma relief. Often our long-term acting medications, such as salmeterol, is for that chronic asthma management and COPD. Our adverse effects are going to be the patient may report after they use a puff of their albuterol, maybe they're having an asthma attack. They may report that they have a higher heart rate. They're going to have maybe some chest pain. They're going to have tremors. They're going to feel nervous and shaky. And their sugar might be high because steroids. They're going to often be used with steroids. Steroids are going to make their sugars go high. Because you know what? Since the body stimulates that sympathetic nervous system, more sugar is going to be needed in the cells for energy. And that's why their sugars are going to be higher. Because this medication mimics the sympathetic nervous system, meaning hyperglycemia is an effect of that. Because it's basically stimulating a stressful state. A consideration with bronchodilator administration is we need to always make sure the patient takes that medication as prescribed and does not overuse the medication. And they need to know the difference of when to use a short-acting medication and a long-acting medication. Remember, we never use these medications alone in asthma treatment. We always are going to use them with a steroid. And the problem with overuse is we don't want that patient's asthma to not be treated. We want to make sure that they're not abusing the medication, and we want to make sure there's nothing else serious going on. We want to make sure they're not going into a chronic asthma state. We want to also make sure that they don't use a long-term medication for use of an asthma attack. So, very much education here. Now we're going to talk about our steroids. So, steroids can be used in various different ways for various parts of the body. We can use steroids almost anywhere. It can be systemic. It can be nasal. A lot of our inhaled glucosteroids are going to be for our asthma patients. So the action of steroids are to stop the inflammatory process in the lungs. It's going to prevent bronchial constriction. It stabilizes white blood cell membranes that release those bronchial-constricting substances. It increases bronchial smooth muscle beta-adrenergic stimulation, meaning it's going to help dilate those bronchi. We usually are going to use that inhaled for asthma treatment because it's going to be the most tolerated and fast-acting, but may also be used IV for other effects on the body. Maybe the patient is in the hospital for something else, and they're getting IV steroids. Well, we can use that as well. Some adverse effects of steroids is high blood sugar, of course, throat and mouth irritation because of the spray, dry mouth, and oral fungal infections. We always want to use this medication with another medication for asthma control. Remember, we need to teach our patients to rinse their mouth out after the steroid use to prevent oral fungal infections, and always take that bronchodilator 5 minutes before the steroid. Always B before C. Now we're going to talk about trypotropium. So trypotropium is an anticholinergic medication used to treat maintenance therapy and bronchospasm in patients with COPD. So this medication is more for your COPD patients, and it's going to help block mucosteric receptors in the lungs. Can't pronounce that word right, so I apologize. It's going to be an inhaled form, and it's going to be for COPD patients because a lot of our COPD patients, they have a problem with getting air in and out of the lungs. There might be mucus in the lungs, and having an anticholinergic medication is going to help dry those muscles up, or those mucus areas up. So, with any anticholinergic medication, remember your side effects. can't see. They cannot see. It blurs their vision. Can't spit. It's going to cause dry mouth. Remember, we can minimize that dry mouth by drinking fluids or sucking on hard candy. Can't pee. It's going to reduce that kidney function. It's going to reduce urine production. Remember, you can always give fluids for that to help. And it can't poop. It's going to cause constipation. Some of the therapeutic effects of using tiotropium is that these effects are going to start 30 minutes post-inhalation. It's going to peak within 3 hours of use, and it's going to last 24 hours. With consistent dosing, the bronchodilation is going to improve. So that's a good thing about the medication. Now we're going to talk about over-the-counter sympathomimetics used in our cardiac patients. So our sympathomimetics can stimulate the immune system, such as our over-the-counter decongestants, such as Simedron, are types of these medications. Patients with cardiac problems must have caution with these drugs and hypertensive treatment because these medications may cause hypertension, hypotension, orthostatic hypotension, and we don't want that to occur. We don't want any of those heart blocks, arrhythmias to occur with these patients. So we would advise to not use an over-the-counter decongestion without a provider's permission. Now we're going to talk about treatment principles of cold symptoms in children. So many medications used over the counter to treat colds are combination medications. For example, right here I have some Dayquil. So the medications used in this formula are acetaminophen, dextromethorphan, guaifenesin, and phenylprenate hydrochloric acid, HCl. And this is a combination medication because there's at least 3 or 4 medications used in this formula to help treat cold and flu symptoms. With our pediatric populations, we cannot use this medication as it can be dangerous if used for colds. Remember, some education we must do is to always treat the individual symptoms only with approved medication. For example, if the patient has a runny nose or a fever, we're going to use a fever reducer for that. We're not going to use a combination medication like Dayquil. We need to treat those individual symptoms to prevent any other hazardous things going into our patient. Remember, we need to follow adequate dosing with these medications, and we should always advise the parent to use medications only indicated for pediatric use because the dosage is going to be much lower in case there is any problems with the dosing. It's going to be less dangerous. Now we're going to switch gears and talk about our GI system. It's a good system to know. You're going to be giving a lot of these medications to patients in the hospital because a lot of patients will come in with stomach pain. So, a little sip of water. So we're going to first talk about ulcer prevention with chronic NSAID use. So, NSAIDs inhibit prostaglandin biosynthesis and reduce blood flow, mucus, and bicarbonate. NSAIDs increase the risk of ulcers forming. So our best treatment of NSAID ulcers is going to be with that PPI medication. We want to make sure that the patient is treated with that PPI and that they stop the NSAID medication as well. Because the problem with NSAIDs is that they're going to increase that chance of the ulcer forming. But if they need that NSAID, we need to make sure that we let the doctor know that they're going to be taking those medications as well. Because once we stop the NSAIDs, those NSAID ulcer risk is going to decrease. But maybe they need the NSAID for arthritis. So we need to make sure that we definitely collaborate with the provider to reduce those NSAID ulcers. Antacids and clomidine. So, we need to define both these medications first. So antacids are used to help neutralize acid secretions and promote gastric mucosal defenses in many ways, and produce pain with acid-related disorders. So antacids basically decrease the amount of acids in the stomach. There's many different types out there: MAC salts, calcium carbonate, or your Tums, sodium bicarbonate, methicone, etc. Various side effects will come with the different types of medications that you use. Over the counter, a lot of these antacids are going to be over the counter. So you can use constipation, diarrhea, metabolic acidosis, calcium carbonate, increased acidity, renal calculi. I'm going to talk about B in a minute. So now we need to know what clomidine does. So clomidine is a H2 receptor blocker that works to block H2 receptors, reduce H ion secretion in parietal cells, suppress acid secretion, and increase stomach pH. So, our adverse effects of clomidine is central nervous system confusion and depression in older adults, decreased libido, impotence, and gynecomastia. We need to caution with patients that are older adults because confusion and depression may occur and they're at a higher risk of developing those conditions. And also we need to, if they report that decreased libido and impotence, they may need to switch that medication. It can be given IV bolus. We need to watch out for hypotension and dysrhythmias. Now, when we take antacids and clomidine together, it can reduce the absorption of clomidine. Antacids reduce the ability of many drugs to be absorbed in the body. So because of this, we need to make sure that we educate our patient to wait 1 hour before taking clomidine and antacids. And we should always call the provider before you buy the over-the-counters because we want to make sure that these reactions don't occur. So the provider may want to give important information regarding teaching for clomidine and antacids. And they may want to tell them, hey, don't buy this medication. Come see me a week later. So we need to make sure that we always clarify with the provider before doing anything. Now we're going to talk about GERD. Good old GERD. Very common. So with gastroesophageal reflux disease, or GERD, there's a problem with the lower esophageal sphincter. Because of this, there's acid that's building up and going up into the esophagus from the stomach. It can cause a lot of irritation, it can cause Barrett's esophagus, and it can cause ulcers, and even cancer if it's not treated. So, a lot of our patients with GERD may actually be given a PPI to help, because the proton pump inhibitor is going to help that ulcer formation. Once the patient stops the PPI, they can relapse and have GERD symptoms. So that is why often a PPI will be taken long-term for GERD, because we don't want that patient to have that relapse of those GERD symptoms again. But we may use these short-term as well for other concerns, like an ulcer maybe. Maybe they have H. pylori infection. Well, maybe not that, but they'll have that ulcer. We're not going to use that for H. pylori. We're going to use antibiotics. Now, since we've mentioned PPIs, we're going to go into a little bit more information about these medications, because they're very common in the healthcare field. So, proton pump inhibitors such as omeprazole and pantoprazole, so it's going to be a lot of your Prezol medications. These medications help to prevent movement of hydrogen ions into the stomach, causing all gastric secretions to be blocked and no HCl to be produced. They help GERD, esophagitis, gastric ulcers, NSAID ulcers, stress ulcers, and H. pylori ulcers. Some adverse effects with this medication is going to be GI effects, diarrhea, nausea, vomiting. Some other effects: pneumonia, osteoporosis, fractures, hypomagnesemia, C. difficile, and gastric cancers. It can be administered various ways: PO, IV, and G-tube. So one thing we need to point out with PPI use is use in older adults. A lot of our older adults are going to suffer from osteoporosis and fractures just because they're at a higher risk. So, We absolutely must encourage our older adults to get adequate calcium and vitamin D. Whether it be a supplement, higher foods, maybe they drink some more milk, maybe they spend a little bit more time out in the sun. Because we don't want them getting fractures or osteoporosis from PPI use. Alrighty. Next we have sulcrophate. So sulcrophate, remember, kind of like create. So sulcrophate is a cytoprotective drug that can treat stress ulcers and peptic ulcer disease. So this medication is actually very interesting because it works by attaching and binding to the base of ulcers and forms like a band-aid or barrier over the ulcer. So sulcrophate creating a band-aid. That's how I remember it. It can then protect that area from pepsin that can break down protein and make the ulcer worse. So these are a good drug. Some adverse effects are constipation, nausea, and dry mouth. But the problem is here is it can inhibit absorption of other drugs. So we have to give these other drugs 2 hours before we give sulcrophate. And of course, antacids are going to interfere, but we already know antacids block many effects from many medications. It's going to bind with phosphate and reduce levels in renal patients, so be cautious with use in renal patients. Now we're going to talk about constipation and laxatives. Woohoo! So constipation occurs when the patient has hard stools, infrequent stools, excessive straining, and unsuccessful defecation. So, before you give a patient any medications to relieve constipation, you must assess the patient. We want to make sure to rule out small bowel obstruction or like an ileus, and we can do this with doing x-ray, listening to the bowel tones, and we also need to rule out that diet's a cause. We need to make sure that that patient's getting adequate fiber and fluids, and we can correct it in the diet that way. So if diet does not help, or if we rule out that the patient's not having a small bowel obstruction or any other problem, and it's pure constipation, we can give laxative to help soften stool. So laxatives help reduce painful bowel elimination, decrease strain to prevent vasovagal stimulation, empty the bowel before treatment procedures, obtain fresh stool samples, and assist with loss of bowel tones. Now we're going to get into the types of laxatives. There are many types of laxatives we will use with our patients. So one kind is bulk-forming laxatives. So bulk-forming laxatives work by absorbing water to increase the bulk and soften the stool. It can cause bowel distension to initiate reflex bowel activity. So these medications just increase bulk and soften the stool. They don't work to initiate that bowel activity. Because of that bowel distension and from the action of the medications, yes, the body may resume bowel function. So how do we give this medication? So we have to give the patient a bulk-forming laxative with a full cup of juice or water. Very important for that. Because that water is going to help increase that bulk with the medication in the digestive system. Opiate use. So opiates work to decrease bowel motility and reduce pain by relief of muscle spasms. They decrease the transit time of stool through the bowel and allow more time for water and electrolytes to be absorbed. So, opiates, they kind of restrict the bowel movement, allowing for the water and electrolytes to be absorbed and for the stool to be more formed. It helps with patients with frequent diarrhea, to decrease stool and ileostomy, and decrease diarrhea from opioid withdrawal. However, a lot of these opiates work similar to opioid medications. And a very familiar side effect of opioid medications is constipation. So, if a patient takes too much of an opiate, due to its dependent effects, a patient may actually experience signs and symptoms similar to morphine, which may cause increased constipation. It can also cause respiratory depression and a lot of other things. But we will need to give naloxone to help reverse the cause because naloxone is the antidote for opioids. Now we're going to talk about senna. So, senna is a stimulant of the intestines and works to increase peristalsis in the intestinal nerve stimulation. A big side effect of senna use is that the patient may have yellow, brown, or pink color to the urine that is harmless. We must teach this side effect before we give the patient the medication so they know to expect this. We don't want that patient having yellow, pink stool or urine because of senna and they realize and they freak out about it. We need to teach this before we give the medication. A big key thing is to always teach something before you do it. That's why we give pre-op teaching about the post-op period and that pre-op period. So, now we're going to talk about probably a very common medication, ondansetron. So, ondansetron is a serotonin agonist that blocks receptors in the vagal nerve, GI tract, and chemoreceptor trigger zones in the central nervous system. So, ondansetron is used to treat a lot of your nausea and vomiting for various different conditions, for various different medications. We can use it to treat chemotherapy-induced nausea vomiting or post-op nausea vomiting, but also it's going to be given a lot for just any nausea vomiting. Some of the side effects that we can have with the medication is diarrhea, dizziness, of course, from the nausea, headache, prolonged QT interval, and risk of torsades T points. So we need to make sure that the patient tells us if they're feeling any chest pain, palpitations, or anything, because we want to make sure that their heart's doing okay. Alrighty. So I'm going to stop this recording here. In part 2, we're going to actually start with our cardiac drugs. We're going to start with our cardiac drugs. So I'm going to stop the recording. And in part 2, we'll go over our cardiac drugs and our diuretics.